Welcome to today's presentation on ensuring gender-affirmative healthcare for transgender and gender-diverse youth. I'm Dr. Jason Rafferty. I'm a pediatrician and child psychiatrist for Thunder Miss Health Centers here in Rhode Island, as well as Emma Pendleton Bradley Hospital. This activity today is brought to you by the Academy for Continued Healthcare Learning. Our learning objectives include being able to outline relevant terminology related to gender care, describing the stigma and healthcare disparities that affect children and adolescents who are transgender or gender diverse, and discussing strategies to ensure gender-affirmative healthcare for transgender and gender diverse youth. So I want to start by going over some terminology. First of all, the difference between sex and gender identity. Sex is usually a term or an assignment that's usually made at the time of birth, often as male or female, based on someone's external genitalia, based on their anatomy, based on their presentation. Gender identity, on the other hand, is sort of a deeper inner sense of whether you're male, female, a combination of both, somewhere in between, or maybe there's some fluidity among different sort of identities. Gender identity is often split among three different domains: the inner identity, the outward expression in terms of how you present yourself to the world, as well as your gender perception, which is how the world perceives you. A term that we'll be using a lot today is gender diverse. Gender diverse really is used to describe people with gender behaviors, appearances, identities that are incongruent with those culturally assigned to their birth sex. It's a large umbrella term. Another large umbrella term that we're going to use is transgender, which is really a subset of people whose gender identity does not match their assigned sex at birth and generally remains persistent, consistent, and insistent over time. Being transgender is sort of compared to being cisgender. Cisgender means that you identify or experience a gender that is consistent with the sex that you were assigned at birth. In addition, another term that comes up a lot is sexual orientation. Sexual orientation refers to a person's sexual identity in relation to the genders in which they're attracted. Sexual orientation and gender identity develop separately, but sometimes they can have a complex interaction. So for example, gender identity is not synonymous with sexual orientation, as I said, and a person who's transgender still identifies as straight, gay, bisexual, or something else. Yet these concepts can be interrelated, because if your partner comes out as trans, you may go from using a label of straight to a label of gay. It's very complicated. A couple more terms that I want to also bring to your attention. One is acceptance, which is a process where individuals and their social contacts, whether it be family, friends, or other people in their life, recognize one's true identity as favorable and deserving of respect. Acceptance and rejection are not black and white, as most people have varying levels of both at any given time. And finally, gender affirmation is what we're going to be talking about today, and it's the process of psychologically, socially, medically, and surgically intervening in a way that allows people to present to society in a manner that's more consistent with their underlying deep sense of gender identity. One question that comes up when we talk about terminology is, how should you refer to a person who's gender diverse? Well, really, it all depends on the label that they want to use. Labels can be really confusing, and they're continually evolving. The best approach that I recommend to people is just to ask directly and non-judgmentally what name, pronouns, and if there's any labels that they would prefer that you use. This provides an opportunity for the person also to discuss their experiences and feelings before making any assumptions. In terms of diagnosis, there's a few terms to be aware of. Back with the DSM-4, people used to diagnose those who are gender diverse using the term gender identity disorder. In terms of the description of that, it was really strongly focused on the cross-gender identification and cross-gender identification, whereas just by being transgender or gender diverse, you inherently had this diagnosis. With DSM-5, there was some evolution in that we moved from just the identification to really focusing on a person's experience. DSM-5's gender dysphoria is defined as incongruence between one's experience and expressed gender that must be at least 6 months of duration. I think what we've learned there with the shift is that there can be some people who are transgender who may not experience a high level of distress because they're in an environment that's very supportive and affirming. I also want to point out that the ICD-11 World Health Organization classification has also shifted a little further with their definition of gender incongruence, which essentially moves gender diversity out of the chapter on mental and behavioral health disorders into a new chapter on conditions related to sexual health. This reflects current knowledge that trans-related and gender-diverse identities are not conditions of mental illness, and it also helps assure that all trans people are able to access gender-affirming healthcare treatments. The definition of gender dysphoria, as I talked about, was definitely an important step forward in how we conceptualize, some of the distress and incongruence that people can feel when their outer presentation doesn't match their inner identity. It's classified a little bit differently for children compared to adolescents. And there's still room to improve on this diagnosis. A lot of times, a lot of the sort of characteristics in the diagnosis still talk about comparing one sex to the other sex. For example, one facet of the diagnosis is having a strong desire to be of the other gender. And this comes up a little short when we talk about populations and people who are non-binary, gender diverse, or other more complex gender presentations that may not be encompassed by this diagnostic criteria. I want to talk a little bit about some of the numbers in terms of transgender identity. There's not a really great large scale sort of survey across the United States or even globally that sort of has taken into account various populations. But one of the areas what we often point to, especially for adolescents, is the Youth Risk Behavioral Survey, which was last done in 2017. In that survey, they found that, and I will say this survey is done in 19 states and among large urban school districts. And what they found was about 1.8% of high school students saying that they use the term transgender. An additional 1.6 said that they weren't really sure if they were transgender, and 2% didn't really know what the question was asking and may actually be developmentally a little bit before really exploring that element of their identity. There are also, when we think about folks who are transgender, there are some important health disparities. The Youth Risk Behavioral Survey from that year also found that 27% of high school students who identified as transgender felt unsafe at or traveling to school. 35% experienced bullying. Over 50% felt sad or hopeless on a regular basis. And 35% reported attempting suicide within the last 12 months. The Williams Institute in California has also done some studies looking at lifetime risks in disparities. They found that the lifetime suicide attempt rate among folks who are transgender was about 41% back in 2015, their last survey. That's compared to about 4% among the U.S. general population, so a magnitude higher. Lifetime depression rates were about 57%, anxiety 40%, and victimization of physical or sexual assault was 60 or more percent. So where does this, one of the big questions is, where do these sort of negative mental health and social sort of outcomes come from? And there's a lot of different theories out there, but I think the one that we often point to most frequently is the minority stress theory. There's been quite a bit of research looking at lesbian, gay, and bisexual populations compared to heterosexual populations, where it's found that on a daily or regular basis, they experience different forms of discrimination, microaggressions, things like peer victimization, maybe parental guilt, or parental disapproval of their sexual orientation or behaviors associated with such, parental anger or outbursts, or parental rejection. And that as you experience those over and over on a regular basis, it drives fear of negative social, sort of evaluation, negative sort of social exclusion, lack of social support, and substance use sort of being a norm in terms of being able to cope with some of that stress, which over time and sort of experience can lead to a number of important negative mental health outcomes. There's also been one study looking at this model, the Hendricks et al., 2012, that has looked at this model among gender minority populations, so people who are transgender and gender diverse. And they propose a very similar framework that looks at sort of external stressors in the environment, microaggressions or rejection or feeling a lack of social support, and how that's sort of internalized over time, which really leads to a negative self-concept, negative self-esteem. And as this perpetuates and is reinforced by mechanisms such as peer policing, parental rejection, and so forth, it can lead to negative behavioral health problems. This actually took it a step further and suggested that the stress, the increased cortisol levels, the sort of physical stress over time can actually even predispose you to negative physical health problems later on in life. Things like cardiac disease or even high-risk behaviors that can lead to increased rates of injury. The other thing that I think really is important to think about is how various aspects of a young person's life interact. We call this intersectionality, where various stressors or traumas throughout somebody's lives accumulate, and they don't necessarily accumulate in a stepwise manner. Sometimes they can, one can really propagate or exponentiate the effect of another. Things like stigma, lack of family support, rigid gender norms, negative peer relationships, bullying, as we've talked about, can all add up and even build upon each other to really set the stage for some negative outcomes. We can talk a little bit about adversity faced by transgender and gender diverse youth. In one study out of Minnesota, 2016, out of 80,000 high school students that were surveyed, transgender students and those with gender diverse behaviors were most likely to experience dysfunction in their home, including psychological and physical abuse. And that really points, through the study, they really sort of point to this, as really showing how, there's overlap between these various risk factors. A 2021 National School Climate Survey showed that LGBTQ plus students 30% missed at least one day of school in the past month. 80% about avoided school functions or extracurricular activities. 75% or more experienced in-person verbal harassment. Over 70% reported negative remarks about their gender expression, and 30% were physically harassed. In another study out of California, it was found that there was also a high level of overlap between LGBTQ youth and representation in the foster care system, as well as being in unstable housing environments. And so you can sort of see how these disparities all sort of, can build one on another and overlap in ways that really put these populations at risk. So what can we do in response? I want to talk a little bit specifically about what gender affirmative care is. Current research suggests that rather than predicting or preventing who a child may become, it's better to value them for who they are now, even at a young age. This fosters attachment and resiliency. Gender affirmative care is based on the belief that all children benefit from love and support. The goal of gender affirmative care is not treatment. It's to listen to the child and with the help of parents and families to build understanding. That through strong, non-judgmental partnerships with patients and their families, providers can create an environment of safety in which complicated emotions, questions, and concerns related to gender can be appreciated and explored. Gender affirmative care is most effective in a collaborative system with access to medical care, mental health, social services, including specific resources for parents and families. The original premises of the gender affirmative care model really sets a framework for when somebody says that they're a gender affirmative provider, what it is that they believe and what are the main principles guiding their practice. There are 4 principles that come out of a Hidalgo editorial back in 2013 that really has become the sort of focal point of the field. Those are transgender identities and gender diverse expressions do not constitute a mental disorder. That variations in gender identity and expression are normal aspects of human diversity, and binary definitions of gender do not always reflect emerging gender identities. Gender identity involves an interplay of biology, development, socialization, and culture, and that if a mental health issue exists, it most often stems from stigma and negative experiences, as we talked about, the minority stress theory, rather than being intrinsic to the child's gender identity. Gender affirmative care can be further divided into a number of different interventions. There's no specific sequence, and there's no necessity of any specific intervention. The pathway through gender affirmation is personalized and individual for everybody that comes into the clinic. So to go through some of those, emotional affirmation is creating safe space for patients and families to explore their gender, share concerns, talk about their emotions openly, and learn to advocate. It includes early identification of dysphoria and other mental health care concerns. This is really something that can be done at any age and obviously is fully reversible. Social affirmation is allowing the young person to adopt gender-affirming hairstyles, clothing, names, pronouns, use of restrooms and other facilities or activities aligned with their gender identity. Again, it can be done at any age and is fully reversible. Legal affirmation is sort of taking the social affirmation one step further and changing gender and gender marker and name on recorded documents such as birth certificates, school records, and other legal documents. Again, this can be done at any age and it's fully reversible. It's a little bit more of an effort, but it can, if you're going to change your name one way or gender marker, you could change it back at any time. In terms of medical interventions, they really fall into two camps. One is puberty blockers, which are gonadotropin-releasing hormone analogs, such as leuprolide or Histrulin. These are often given once puberty has initiated as a reversible way of stopping puberty and allowing some time for the young person really to figure out their gender goals, or sometimes to allow the young person to work with their family to better articulate and explore their identity. The other camp is cross-gender affirming hormones. This would include testosterone for masculinizing effects or estrogen for feminizing effects. In terms of determining when hormones come into play, it's often a complex sort of process of looking at how ready the young person is, at how much they understand the risks and benefits of the treatment that they're looking at, and also socially when they sort of fit in with their peers in terms of some of the characteristics that they may be developing once they start on treatment. We talk about cross-gender affirming hormones as being partially reversible because often there's some characteristics that may go back once they stop and other characteristics that may be irreversible. And then finally, there's gender-affirming surgeries. Often these are split into top surgery, which is largely chest reconstruction, and bottom surgeries, which focus on genital reconstruction. Typically, gender-affirming surgeries are reserved for adult populations, although sometimes there are exceptions in late adolescence, especially for top surgery. But most guidelines do recommend that you're 18 or older. And surgeries are not reversible. The last thing I just want to talk about is family support and the importance of it. Family acceptance of adolescent gender diversity is associated with young adult positive outcomes in terms of self-esteem, social support, and general health. It's also protective for negative health outcomes such as depression, substance abuse, and suicidal ideation and attempts. When I often think of family support and even community support, I often think of it as a way of countering the forces and sort of dynamics that take place in the minority stress model. It's important to understand, though, when working with families and support systems, that acceptance is a process. It's a process of reframing fears and worries, which are often based on uncertainty and can be overwhelming, towards focusing more on how to best support your child or your friend in the here and now. When parents ask me what is the right thing to do for my child, I always tell them it's important to focus on parental acceptance as the most important factor in your child's adjustment to their development and future outlook in life. Parental rejection may lead you to have shame that becomes internalized, as we discussed through the minority stress model. And often this is manifested through secretive thoughts, feelings, behaviors, or even higher risk behaviors. Research shows that even a little less rejection or a little more acceptance has improved outcomes for self-esteem, life satisfaction, decreased risk for depression, suicide, substance use, and HIV. So I often tell families that even them coming to the clinic or being able to have a conversation about their child's goals is a little less rejection or a little more acceptance that can really be meaningful to their child in terms of their future development. I think it's really important to just take a moment and just recognize that all the approaches that we talked about today, the process and the gender affirmative care model, are all individually tailored interventions that need to be based on physical and cognitive development, emotional development, readiness, and really involves a strong partnership between children and both their mental health and their physical health providers. In terms of primary care approaches that are really important to take away from today, I think it's important to recognize that families may first seek support from their primary care providers. So primary care providers really need to be ready to sort of screen for and respond to concerns that may come up around gender identity with ways that can sort of build the child's sense of self, kind of branch off their strengths and really help them in terms of their overall development. Primary care providers can create welcoming offices with posters and flyers that emphasize inclusivity. They can inquire directly, non-judgmentally about a patient's preferences and experience inside the clinic, provide diversity training for clinical administrative staff, and as best as possible, try to reflect the patient's asserted name and pronouns in medical record taking and in electronic medical record systems. So finally, primary care providers can offer patients and families with important resources. They can direct them to support groups and also make referrals, especially to mental health care providers, which can help in the child's exploration and also in the parents' and families' understanding of what their child is going through. So to recap today, we've talked a bit about terms that are important to understand in terms of gender care. We've talked a little bit about some of the health disparities that people who are transgender and gender diverse face, as well as the minority stress model, which kind of explains why these populations may be facing these increased risks of various negative outcomes. And then on the flip side, we talked a little bit about the gender affirmative approach, which are really in concept ways that you can approach care, even at the primary care level, to make things more positive, more strength building, and to counteract some of the minority stress in terms of building resiliency. And then finally, we've talked a little bit about how you can support young people through resources for families, as well as things you can do as a primary care provider to create more environments that are, that are more positive, more supportive, and also more accepting. Well, thank you very much for joining us today. I appreciate the time that you put aside for this. And before you leave, if you wouldn't mind just filling out moving on and filling out the evaluation. Thank you very much.